Welcome to the Neurokrish Immersion, the whole person in dementia, science, soul, and care is what we're addressing today. When memory fades, what remains? Beyond drugs, we have pharmaceutical interventions that alone cannot address the complex, multifaceted nature of dementia and its impact on daily living. Beyond symptoms, we need true care that extends far beyond managing clinical manifestations to encompass dignity, meaning, and quality of life. And of course, we need a comprehensive approach that honors the individual's identity, relationships, and inherent worth throughout the disease journey. Dementia is a growing global crisis. The world faces an unprecedented challenge as prevalence rises exponentially, especially in low and middle income countries. And while pharmaceutical advances have generated headlines, the benefits remain limited, as science is telling us, and the costs are prohibitively high for most families worldwide. The trickle of new treatments to developing nations is painfully slow, creating a widening chasm between those who can access cutting-edge care and those who cannot. This care gap represents not just a medical challenge, but a profound ethical and humanitarian crisis that demands innovative and sustainable solutions. There are 5A barriers in healthcare delivery worldwide, and systems worldwide struggle to provide dementia care that meets fundamental accessibility standards. We need to understand these five critical barriers in order to design interventions that truly serve communities in need. The first A is availability. Our specialized dementia services, trained professionals, and appropriate facilities actually present in the community that you're in. The second is accessibility. Can families physically or digitally reach the services given that we have transportation challenges, distance and mobility limitations in dementia? We also have problems in digital penetration in many low and middle income countries. The third is affordability. Can families sustain the financial burden of long-term care, medications, and support services? The fourth, acceptability. Do the care models align with cultural values, beliefs, and traditional healing practices of the community you're in? And five, accountability. Are robust quality assurance mechanisms in place to ensure safe, effective, and evidence-informed care? Remember these five A's. They are extremely important for all of us to always keep in mind. Now, why does integration of care matter? And is there a case for holistic care? Integration reduces unnecessary suffering while preserving human dignity through disease progression. It is acceptable and aligns more closely with how communities conceptualize healing and wholeness. It addresses the reality that dementia fundamentally affects entire family systems and not just individuals. These are the clinical and ethical imperatives that make us think about integration. On the other hand, from an empowerment and sustainability perspective, family participation transforms passive recipients into active, empowered care partners. Higher satisfaction rates are experienced when families feel heard, valued, and equipped with practical skills to look after the person with dementia. And recognizing dementia as a family illness requiring family-centered interventions is extremely important, therefore. Research shows clear, measurable benefits for multidisciplinary care. Multidisciplinary care improves diagnostic accuracy and significantly reduces time from symptom onset to appropriate intervention. It improves behavioral outcomes by enhancing their management. Please remember, behavioral and psychological symptoms are a huge problem for people with dementia and even more for their families. It measurably improves caregiver quality of life, reduces caregiver burden, and prevents caregiver burnout. And one factor to keep in mind here that very often the person caregiving for the person with dementia is as old or even older than the person with dementia. And that is quite a challenge. It's also better equipped to address the multifaceted challenges that cannot be solved by single discipline approaches. And indeed, there is evidence that multidisciplinary care works better from a number of scientific sources, both original articles and meta-analysis. We must also take the opportunity to acknowledge certain limitations and barriers. Multidisciplinary care is time consuming and coordination across disciplines requires significant administrative effort and clinical time. Multidisciplinary care tends to be resource heavy. Multiple specialists, diverse treatment modalities, and comprehensive assessments demand substantial resources. It can be very difficult to scale and replicate intensive multidisciplinary models across diverse settings. This does pose a major challenge. The upfront costs of multidisciplinary care can be prohibitive, and while we acknowledge that long-term value may justify the investment, we must keep in mind these upfront costs, which make it difficult to scale once again. And of course, outcomes like dignity and meaning, they resist traditional quantification methods, and therefore they are regarded as soft evidence by many professionals. But we must ask here, whose evidence is it anyway? Traditional research paradigms often fail to capture what matters most to patients and families. Absence of evidence in conventional trials does not equal evidence of absence of benefit. And this is something that we would do well to remember. Naturalistic outcomes, therefore, matter when you start considering evidence. And while traditional randomized controlled trials are valuable, they were never designed to evaluate complex multidisciplinary interventions delivered in real-world settings. We need outcome measures that reflect what patients and families actually value in their daily lives. Take, for example, quality of life, measuring the subjective well-being of both patient and caregiver. These outcomes matter to families navigating dementia. Take, for example, activities of daily living, preserving functional independence and meaningful participation in everyday activities that define personhood. Take, for example, symptom reduction, alleviating distressing behavioral and psychological symptoms that diminish quality of life for all involved. And indeed, take, for example, the time to institutionalization, because that's a dreaded outcome for the vast majority of sufferers and families. Extending the period that families can maintain home-based care is a priority for most patients and caregivers. And then, of course, there is a clinical rationale. We have to ask ourselves, why multidisciplinary and multi-component care? What we have today as medication currently only offers marginal clinical benefits with effect sizes that often fail to translate into meaningful functional improvements. Even promising agents like lecanemab await robust proof of widespread sustainable impact of quality of life. Indeed, the latest evidence with regard to drugs like lecanemab indicates that while they do a very good job of getting rid of the waste protein amyloid in your brain, they don't necessarily translate into clinical improvements. And so that's a whole area that we are continuing to watch with bated breath. We still don't have proof that the drugs provide improvement in terms of functional outcomes. And of course, there's a range of psychotropic drugs that end up being prescribed, but they come with the risks of morbidity and mortality in elderly populations, particularly in those with cognitive impairment. And the therapeutic window tends to narrow as the disease progresses. In this landscape, we have growing evidence of non-drug therapies. Neuromodulation, for example, transcranial stimulation, shows promise for cognitive and behavioral outcomes, and we now have a range of possibilities: transcranial electrical stimulation, transcranial magnetic stimulation, which is repetitive, and then, of course, the new TPS, transcranial pulse stimulation. All these are possibilities in terms of non-drug therapies that can improve cognition and improve behavioral and physical outcomes for the person with dementia. Physical outcomes can be improved through physical interventions. We have the benefits of exercise, Tai Chi, and yoga on mobility, mood, and cognition well demonstrated to us today. Cognitive stimulation through structured activities that maintain neural engagement and functional capacity is another form of non-drug therapy that can work for a person with mild cognitive impairment or dementia. And of course, caregiver training, empowering families, reduces symptoms and prevents crisis situations. So the basket of non-pharmacological care is constantly growing. What then are the public health priorities beyond pharmacology? If we ask, family-based care is probably the most sustainable and meaningful form of care. It helps maintain activities of daily and quality of life, and this is a primary goal. We help to prevent institutionalization and support families to provide care at home as long as possible. We encourage the family to care by creating infrastructure and support systems that enable rather than burden family caregivers, and this can transform the healthcare landscape. And of course, we care for the caregiver, recognizing that caregiver well-being directly impacts patient outcomes and makes caregiver support a clinical priority and not an afterthought. So what has to get integrated into our care models? Cultural alignment needs to get integrated. Approaches that resonate with local values and healing philosophies are extremely important. Patient choice needs to get integrated. Seamless models of care that offer genuine options and respect patient preferences are extremely important. We need a blend of modern scientific evidence and ancient healing wisdom, the best of both worlds, extremely important. And for this, we must consider what local healthcare traditions are, what is already available, and what is already trusted in that community. And finally, it's extremely important that we monitor and document building an evidence base of outcomes, because we need to be able to show that these multidisciplinary approaches have impact. Integration means creating a synergy between modern neuroscience and time-tested healing traditions, allowing each to amplify the other's strengths. Now, when we talk about healing traditions, we come to the whole area of complementary and alternative medicine. And it's very important to remember that this is not something outlandish. Surveys have shown that 40% of US adults with neuropsychiatric symptoms have used complementary and alternative medicine. And it's remarkably common, therefore, yet healthcare systems often fail to acknowledge or integrate these practices into comprehensive care plans. This high utilization by patients on their own, and some of this research actually came from Maulik et al. In the Veterans Affairs Administration, where people were entitled to hospital care free of cost because they were US veterans from the Army or Navy or Air Force. And yet they spent out of pocket on complementary and alternative medicine in about 40% of cases. What this shows is that there is a certain amount of dissatisfaction with conventional treatment and its limitations. And rather than us dismissing these choices, we should thoughtfully integrate these evidence-based methods into formal treatment protocols. CAM in Maulik's study has been used in anxiety disorders, depression and mood disturbances, insomnia and sleep disorders, chronic headache and migraine, memory deficits and cognitive concerns, attention deficit and concentration problems. So, a wide range of neuropsychiatric symptoms. Now, can science and tradition be in harmony? Can they be complementary and not competitive? Traditional systems tend to understand the human being as integrated energy, consciousness, and physical form. Concepts modern science is rediscovering today through a different language. Modern neurotechnology, on the other hand, provides measurable evidence for phenomena traditional healers have observed for millennia, creating bridges for integration. When modern neurotechnology and ancient healing practices work in concert, they create synergistic effects that exceed what either approach could achieve alone. This integration respects both empirical evidence and traditional wisdom. At Buddhi Clinic, we have created a four core pillar model for multidisciplinary care. We start with a comprehensive evaluation that spans neurological, psychological, functional, and holistic dimensions, creating a 360-degree view of the person, not just the disease. We offer coordinated interventions from diverse specialists working as a unified team with shared goals and continuous communication. We focus on what matters most: quality of life, functional independence, caregiver well being, and meaningful daily engagement as holistic outcomes for the patient. And we engage in continuous tracking and monitoring of standard international outcome measures through continuous assessments that follow the entire care process and are dynamic and responsive to the person's journey through the care process. Our multidisciplinary team includes modern doctors, rehabilitators for speech and cognition, psychologists, people who do diagnostic tests like electrophysiology or neuroimaging. We have a team of neuromodulators who offer various forms of neuromodulation. We have mobility experts, physiotherapists, and occupational therapists. We have a range of healers who practice Ayurveda, naturopathy, yoga, and a range of other healthcare traditions, including acupuncture, acupressure, reflexology, Tai Chi, and mindfulness. And we have a team of therapy technicians who are trained to deliver care in a certain way. And they all work in concert as a team. Our patients do receive prescriptions from modern medicine doctors, and of course, they are tracked as they progress through the different domains of engagement that are possible within the Buddhi Clinic ecosystem. Let me use a patient story to explain how this potentially works for people with dementia or mild cognitive impairment. Mr. X is a real world example, a 68-year-old male with a 9-year history of progressive cognitive decline when he came to us. One of the important comorbidities he had was severe plantar fasciitis with pain on an 8 out of 10 scale, limiting not just his mobility but making him extremely annoyed and irritable at many times. He had chronic insomnia with unpredictable mood fluctuations and a marked irritability and a pervasive fear of acquiring COVID thanks to the ongoing COVID-19 infection pandemic at that time. This had a daily impact on him. He needed a rigid daily schedule just to prevent his getting agitated. Despite multiple medicines being tried and conventional approaches being pushed to the limit, he experienced minimal relief. The family was exhausted from managing complex behavioral symptoms, and there was a progressive functional decline affecting activities of daily living. Now, this case illustrates the multifaceted nature of the dementia problem: cognitive decline intertwined with pain, sleep disturbance, mood dysregulation, and family stress. Single modality approaches, not surprisingly, had failed to provide meaningful relief for Mr. X. Our detailed multidisciplinary evaluation showed us the following things. On the neurological evaluation, he had subtle motor findings, but other than that, we did not find any deficits of significance. The physiotherapist identified low back muscle spasm with compensatory postural changes and severe bilateral sole tenderness due to the plantar fasciitis, which limited his ambulation and contributed to activity avoidance. On psychological testing, the clinical interview schedule revised was used, showing significant clinical distress with a score of 28. He responded to the Addenbrook's cognitive examination with a score of 62 on 100, and this confirmed moderate cognitive impairment. The holistic evaluation included the pulse diagnosis and constitutional evaluation, identifying imbalances in Vata and Pitta doshas, providing a framework for integrative interventions. And his EEG showed a borderline normal record with subtle slowing in the temporal regions, but no definitive abnormalities beyond that, which were consistent with the neurodegenerative process. He had extensive blood work, and dyslipidemia was identified, requiring cardiovascular risk management and potentially contributing to what was thought to be vascular cognitive impairment in his case. And the MRI showed volume loss predominantly in the temporoparietal and frontal cortex, consistent with neurodegenerative pattern with multiple lacunar infarcts, suggesting mixed dementia with a vascular contribution. He had the ApoE genotype tested and the E4 allele heterozygous, conferring increased Alzheimer's disease risk and informing a prognosis discussion with family was identified. And on FDG PET, he had hypometabolism in the temporoparietal and frontal lobes, matching the changes in the MRI with hippocampal atrophy, a signature pattern of Alzheimer's disease pathophysiology. He therefore underwent our multidisciplinary care paradigm and was offered a home-based intervention given his particular circumstances. He received optimized pharmacotherapy with a cholinesterase inhibitor, memantine, and targeted symptom management. We had physiotherapy that focused on pain relief and mobility restoration and postural correction, cognitive behavior therapy and cognitive retraining. And here we took the unique opportunity to leverage on his particular interests, which include collecting clocks, collecting lithographs, and engaging in particular forms of music. He had Ayurveda, yoga, and naturopathy tailored to his constitutional needs. The caregivers were educated, and he received 20 sessions of transcranial direct current stimulation targeting his cognitive impairment. The pharmacological interventions, of course, formed a very important foundation of the comprehensive dementia care and addressed his cognitive function, sleep architecture, systemic comorbidities, and nutritional needs. And this multi-targeted approach recognizes that optimal cognitive outcomes require attention to both brain-specific and whole-body health parameters. He received medication like rivastigmine for cognition, melatonin for sleep, clopidogrel, telmisartan, and rosuvastatin to manage his cardiovascular risk factors, and multivitamins, probiotics, and micronutrients as supplements to help with his overall nutrition. The TDCS protocol was a very specific one that modulates neuronal activity through weak electrical currents, and we targeted cortical regions implicated in cognitive and behavioral regulation. And this is a very safe adjunct to pharmacological interventions. Sessions take about 20 minutes, and he had about 20 sessions at the frequency of 4 times per week, followed by 10 sessions at the frequency of 2 times per week. This tapering protocol maintains therapeutic gains while reducing treatment intensity, supporting long-term neural plasticity, and preventing relapse of behavioral symptoms. The placement of the electrodes, the anode was F3, left dorsolateral prefrontal cortex, and the cathode was FP2, the right orbitofrontal cortex. And this montage enhances executive function while modulating his emotional regulation circuits. As part of physiotherapy, he had manual therapy to identify tender spots on soles and areas of muscle tension. He had trigger point release, focus pressure techniques to release light knotted calf muscles, reducing myofascial pain and improving circulation. He had gentle joint movement and pelvic tilts to maintain the range of motion, preventing contractures and reducing stiffness without patient effort, what we call passive mobilization. He was given condition-specific exercises tailored to his abilities, promoting strength, balance, and functional independence. And stretching was focused on plantar fascia and lower extremity flexibility to reduce pain, improve gait mechanics, and enhance his overall mobility. He received a holistic complementary and alternative medicine program that included acupressure, the application of pressure to specific body points based on the traditional meridian theory, promoting relaxation and pain relief through non-invasive stimulation, reflexology, systemic manipulation of reflex zones on the feet corresponding to various body organs, supporting whole body homeostasis and stress reduction, yoga asanas, modified postures adapted for dementia patients, integrating breath work and gentle movement to enhance mind-body awareness and physical function, and chanting, a rhythmic vocalization practice that promotes cognitive engagement, emotional regulation, and spiritual well-being through repetitive sound patterns. These CAM modalities complement conventional treatments by addressing dimensions of wellness often overlooked in standard medical care. They provide non-pharmacological pathways to symptom management while honoring cultural preferences and patient autonomy. He had Ayurvedic interventions that leverage on the many thousand-year-old traditional healing wisdom of Ayurvedic medicine rooted in holistic principles of balance and constitutional harmony. These therapies address the vata disturbances common in dementia using oils, herbs, and touch to calm the nervous system and restore equilibrium. Included were Shiro Abhyangam, a therapeutic head massage using medicated oils, promoting relaxation, improving cerebral circulation, and calming an agitated mind through rhythmic touch. Shirodhara, the continuous stream of warm oil poured over the forehead, the third eye region, inducing profound relaxation, reducing anxiety, and supporting mental clarity. Medicated poultices, warm herbal bundles applied to painful areas, delivering anti-inflammatory botanicals transdermally while providing soothing heat therapy, and constitutional formulations using herbs like Brahmi, Ashwagandha, and Shankapushpi, traditionally valued for cognitive support and nervous system nourishment. He also engaged in naturopathic treatments, nature-based healing, emphasizing the body's inherent healing capacity, using natural elements and minimal intervention. These modalities activate self-healing mechanisms while avoiding pharmaceutical side effects, particularly valuable for patients with polypharmacy concerns. His interventions included water, hydrotherapy techniques using temperature contrast to stimulate circulation, reduce inflammation, and promote detoxification, mud packs, earth-based applications that draw out toxins, reduce local inflammation, and provide mineral-rich therapeutic benefits, herbal preparations that are formulated according to individual constitutional needs and symptom patterns, and individualized treatment plans based on comprehensive assessment of physical, mental, and lifestyle factors. Cognitive remediation therapy was offered. Cognitive remediation employs structured exercises to maintain and potentially enhance cognitive abilities despite neurodegenerative processes. This approach leverages neuroplasticity principles, providing targeted stimulation across multiple cognitive domains while maintaining engagement through varied and meaningful activities. Cognition exercises include recall, sequencing, and finding differences, and thereby challenging attention and processing speed while reinforcing pattern recognition skill. Listening and reading passages with comprehension questions maintain language processing and verbal reasoning abilities. Word building exercises and finding matching pairs strengthen encoding, storage, and retrieval mechanisms across verbal and visual modalities. Discussion of current affairs and movie songs provides culturally relevant stimulation that engages long-term memory and emotional connections, and guided exploration of personal memories reinforces identity, provides emotional validation, and activates preserved autobiographical knowledge, what we call reminiscence therapy. It's also important to work with the caregiver to enhance the patient outcome, and dementia caregiving imposes substantial physical, emotional, and financial burden and is therefore terribly stressful. Managing the caregiver's emotions, working with their anticipatory grief as they see the person fading away, enhancing caregiver quality of life, helping them maintain social connections and their own personal identity and interests while continuing to caregive for the person with dementia, educate them about disease progression and offering behavioral management strategies and realistic expectations is extremely important. And helping the caregiver with their own physical and mental health is very, very important because if the caregiver were not available, the care for the person with dementia, most people with dementia would dip considerably immediately, and thus caregiver well-being becomes extremely important. So, over a period of time, after an intensive program, Mr. X went on to receive a step down program over 20 months with many of these interventions programmed and spaced out. Now, we found remarkable outcomes with this consistent approach. His pain score went from 8 out of 10 at the baseline to 2 out of 10 with enhanced mobility, better activity participation, improved sleep quality, and sustained improvement overall. His behavioral outcomes improved with a 95% symptom reduction, uh, easier care, better quality interactions, significantly decreased behavioral outbursts or emotional dysregulation episodes, better family dynamics, and better caregiver well-being. There was a more consistent emotional baseline with fewer disruptive fluctuations, and his CIS-R score, the clinical interview schedule score, which was 38, plummeted to 2 at the end of this prolonged program. His cognitive functions stabilized very, very well with this therapy. If you remember, he started with an Addenbrook's cognitive examination score of 62, which went up to 72 over the course of therapy and has been maintained between 68 and 72 for a prolonged period. Any drops in cognition have usually followed intercurrent illness or intercurrent disturbance due to familial travel or a change in routine, but it's always restored back to where it had been achieved, the score of 68 to 72 being well maintained. And overall, therefore, there was a holistic impact that the person was able to perceive and the family was able to perceive. We learned lessons working with Mr. X and people like Mr. X. And here are some key principles, 8 of them actually, that we use. Scheduling activities wisely seems to be extremely important for people with mild cognitive impairment and dementia. Taking time, anticipating that things will take longer to do is extremely important. Rushing through activities causes a lot of distress both to the person and the caregiver. Involving the person and maintaining their engagement by identifying things that they enjoyed or have hitherto enjoyed are extremely important. And you'll remember my talking about this particular person's interest in clocks and lithographs and music. Those proved to be extremely engaging in working with him, and he did not see the tasks that we were offering as burdensome as a consequence. Offering choices, simple binary choices, helps the person preserve their autonomy without being overwhelmed. For example, would you like tea or coffee? Is a very simple binary choice that one is able to offer. It helps the person maintain their autonomy. Breaking their tasks into single steps using clear, concrete language and demonstrating when possible makes it very easy for the person who's suffering from mild cognitive impairment or dementia. Abstract or multi-step directions are unhelpful. Minimizing competing stimuli during tasks or conversation is extremely important. Turn off the television, close doors, focus attention to support processing. Distractions are something that does not help the person with dementia. Offering reassurance in form of frequent emotional support, it helps to reduce anxiety, and rather than correcting a wrong that the person may be saying or doing, it's better to offer responses to their feelings and reassurance, or indeed firm patient guidance. And periodically reassessing the progress that is being made is very important, and being able to rejig one's approach to the person with dementia, keeping their own progress in mind, is also very, very important. In terms of everyday life, its routine and schedules are important because they provide the consistency they provide reduces anxiety, creates predictable patterns, and having a regular timing for meals, activities, and rest supports both cognitions and emotions in a very stable way. Structure tends to compensate for impaired planning abilities. It allows preserved capacities to function optimally within a supportive framework. Maintaining dignity through meaningful participation in activities within their capability is extremely important, and rather than worrying about what has been lost, being able to honor the remaining abilities is extremely important. Autonomy is, as we've said before, very, very important, and supporting this through choice offering and collaborative problem solving can be very, very valuable. Even small decisions preserve the sense of control and personal identity that are so important to each and every one of us. Environmental modifications that reduce distractions by creating calm spaces with minimal competing stimuli, because visual and auditory clutter overwhelms compromised neural processing. Simplify the environment while maintaining familiarity. Remove hazards but preserve meaningful personal items that support memory and identity for the person. So, how is this multidisciplinary approach of Buddhi different? There are 5 distinguishing features. It's a team approach. It's a truly multidisciplinary collaboration integrating neurology, psychiatry, physical therapy, holistic therapy, and psychological therapy in a coordinated way. Service, which not is not just provided in the centers but is also provided at the doorstep, as it was for this particular individual, is extremely important. It removes the barriers of transportation, and it also prevents bringing the person to unfamiliar environments, and By this, we are able to provide care in the most comfortable and familiar setting. Our approach has been process driven and rigorous. We use a cloud based electronic medical record, and this ensures systematic documentation, standardized assessments, and data driven decision making across interventions. We have tracked progress regularly for this patient, regular administration of validated tools like the Addenbrook's cognitive examination, the clinical interview schedule revised, the pain scales. It provides an objective outcome measurement and informs treatment adjustments. And of course, the integration of modern tech with ancient treatments, both neuromodulation and time-tested Ayurveda, naturopathy, this combined wisdom creates a complementary therapeutic strategy. So, we do have, therefore, many ways of thinking about things, and I'm going to compare what we say in ancient terms with the modern parallel. When we talk about nadis or energy channels in ancient Indian healthcare wisdom, the modern parallel are neural networks and facial connectivity. When we talk about meditation practices in ancient Indian wisdom, the modern parallel is neuroplasticity and default mode network modulation. When we talk about Prakriti or constitutional diagnosis, the modern parallel is personalized medicine with genomic profiling. When we talk about mind body integration in ancient Indian wisdom, we are now discussing in the modern parallel gut brain immune axis and psychoneuroimmunology. When we talk about prana or the life force in ancient wisdom, we are now talking about mitochondrial function and cellular energy metabolism in the modern parallel. And we talk about the dosha balance in ancient wisdom. We are talking about homeostasis and systems biology in the modern parallel. Ancient healing systems and modern neuroscience, therefore, often describe similar phenomena using different language. And rather than competing, these frameworks can inform and enrich one another, offering complementary perspectives on human health and disease. Recognition of these parallels allows clinicians to draw on both scientific evidence and traditional wisdom, creating richer, more individualized treatment approaches. What we need, therefore, is harmony, not competition in clinical practice. What we need is a complementary approach and not a competitive approach. Traditional and modern approaches amplify outcomes together. Ancient systems offer frameworks for individualization, attention to subtle symptoms, and holistic understanding. Modern science provides mechanistic insight, standardized measurement, and evidence based protocols. Integration allows us to leverage strengths of both paradigms, the technological precision of TDCS alongside the constitutional wisdom of Ayurveda, the validated outcomes of cognitive remediation alongside the spiritual grounding of yoga and chanting. The result, more comprehensive, culturally resonant, person centered care that addresses biological, psychological, social, and spiritual dimensions of healing, moving beyond either or thinking to embrace both and various possibilities. And really, what we must think about in public health is measuring what truly matters in dementia care, looking beyond traditional clinical metrics. We must capture the lived experience of both patients and their families alongside functional outcomes that reflect real world impact. And therefore, what we should measure are another set of outcomes, primarily quality of life of both patient and caregiver using validated measurements, activities of daily life and maintaining and functional independence, symptom reduction, including behavioral and psychological manifestations, and time to institutionalization as a marker of home-based care sustainability. Secondary outcomes include caregiver burden, satisfaction, and overall well-being, cost effectiveness from a healthcare system and societal perspective, adverse events and safety monitoring, and healthcare service utilization patterns and resource consumption. Effective evaluation of integrated dementia care therefore requires a comprehensive measurement framework that captures both clinical outcomes and quality of life indicators. Our proposed measures balance rigorous assessment with practical implementation considerations. Can this model grow? There are, of course, implementation challenges. It's resource intensive, requiring sustained commitment. It requires multiple specialized professionals. It requires a complex coordination infrastructure. It requires comprehensive training requirements. And of course, there are significant upfront and ongoing costs in providing care of this nature. What can we do to scale? We can offer tiered model with both intensive and lighter touch options. We can try to bring in train the trainer approaches, multiplying our expertise. We can go technology assisted for delivery, including reduction of resource demands. We could use cloud-based EMR, enabling rapid replication. And of course, we could culturally adapt our care to diverse population. Scaling comprehensive dementia care does require innovative approaches that balance fidelity to core principles with practical implementation realities. By developing flexible delivery models and leveraging technology, we can expand access while maintaining quality. And what must we do to advance our evidence based? We need multi site naturalistic studies, we need a component analysis. We need to understand which specific interventions help people most. We must bring in a component of biomarker research. We must carry out economic analysis. We must look at cross-cultural adaptations of care. And of course, we must integrate digital tools, remote monitoring, and telehealth platforms in order to make this successful. Today, we are able to innovate through technology, wearable devices, AI-assisted personalization, virtual reality rehabilitation, telemedicine expansion, digital cognitive training, and remote caregiver support are all realities of the modern age. And integrating these is going to be extremely important as we move ahead. We need to therefore transform dementia care from fragmented medical management to comprehensive person-centered support. And this requires fundamental policy shifts. These changes must occur at institutional, regulatory, and societal levels to enable sustainable implementation. We must have models of recognition and reimbursement. We must have a reform of training curricula across the board, medical, nursing, and allied health education. We must redesign quality metrics, go beyond medication adherence and hospitalization rates to capture person-centered outcomes, as we've been saying. We must provide family caregiver support, recognizing family caregivers as the essential care team members, and we must look at cultural competency standards. There must be cultural humility training and development of culturally adapted assessment tools and interventions in across the board. There is potential to disseminate this globally, and this both the model's design principles are are such that we can adapt them across diverse cultural contexts and healthcare system. It's a process-driven approach which transcends specific cultural practices while honoring local healing traditions. In summary, what Buddhi has demonstrated as a dementia comprehensive care model is process-driven, it's culturally adaptable, it's evidence generating, and it's scalable in its implementation. Integrated dementia care implemented worldwide, thoughtfully adapted to honor local contexts while maintaining fidelity to person-centered, family-inclusive, evidence-based principles is therefore the vision with which we are working. We have some key insights to share. As part of this journey, dementia is a family illness, not just an illness of a person. Family care is sustainable and meaningful. Integration of care complements pharmacotherapy. The goal must not only be to treat, but to also heal. And our mission must be to preserve life essence. We go back to our opening question. When memory fades, what remains? Please remember, people with dementia have capacity for joy and connection. They have the ability to experience comfort. They have the potential for meaning, and meaningful moments and activities continue to resonate with them. There is the preserved personhood. The essential self persists beyond cognitive function, expressing through emotion, preference, and relationship. Relationships are transformed. Connections evolve rather than disappear, often deepening in unexpected ways when cognitive demands are reduced. An inherent human dignity remains, regardless of cognitive status, deserving recognition and respect. Finally, quality of life, well-being, comfort, and lifestyle satisfaction remain achievable goals throughout the disease trajectory. And this is why we need the whole person paradigm that puts the person in the center, focuses on all that truly matters, involves the whole family, and brings together the whole heritage of healing that is accessible to us. Our challenges remain healthcare systems that value holistic care. We wish there were more of them. Training programs for multidisciplinary specialists, these are few and far between. Research that documents outcomes rigorously, we wish we did more of that. Policy recognizing family caregivers, and this is so important, and yet many governments are yet to come to that. And transformed societal attitudes towards this inevitable decline as we age. And that is something that we all must acknowledge and keep in mind. And this is a call to action, therefore, for clinicians, researchers, policymakers, educators, and families, those affected and those who are not, to think differently about whole person care and center those thoughts on people with mild cognitive impairment and dementia. When memory fades, what remains, not only to treat but to heal, not just to prolong life but to preserve its essence. Whole person, whole family, whole care. Much remains, and how we choose to care for that much makes all the difference. Thank you for listening. If you found this valuable, please subscribe, like, and share. We are on Spotify, Apple, and YouTube.